Yeah. So the objectives for the talk today are we'll understand the various parameters to set an high frequency ventilator. Second is a little bit about the factors which are influencing each of these parameters, and then the parameter settings in individual disease scenarios. So coming to the knobology means the knobs to set in a conventional ventilator versus the high frequency ventilator. So in a conventional ventilator, as we all know, these are the parameters to set. That is the peak inspiratory pressure, end expiratory pressure, respiratory rate, inspiratory time, flow, and FiO2. As opposed to that, in the high frequency ventilator, the parameters to set are five. They are the mean airway pressure, amplitude, frequency, inspiratory to expiratory ratio, and the fraction of inspired oxygen or FiO2. Okay. So if you see, this is the breath which is delivered in a conventional ventilation. Okay. So you have a yeah. So if you see at the base, there is PWP. When the breath starts, it starts with yeah. So this one is the positive positive end expiratory pressure. Then after that, the ventilator breath will start. Okay, and this delivers the PIP, and then once the inspiration ends, again your expiration starts. So this is what happens during a conventional breath. Okay, and somewhere in between this positive end expiratory pressure and PIP, you have your mean airway pressure. Okay, which is constantly maintained throughout the respiratory cycle. Okay. Opposed to that, what happens in a high frequency ventilation? So there is a constant descending pressure as happens in a CPAP. Okay, so it is which we call the mean airway pressure. So in CPAP, we have positive end expiratory pressure. Okay, similar to that, a constant descending pressure is applied throughout the respiratory cycle. That is your mean airway pressure. Okay, so this dotted line which you see here, this is your mean airway pressure, and the pressure then keeps on fluctuating plus or minus on this mean airway pressure based on the amplitude you set. Okay, so suppose you set a mean airway pressure of 10 and amplitude of 10. So what will happen is that the ventilator mean airway pressure which will be delivered will be constantly 10, and the pressures will fluctuate plus 5 minus 5 because you have set an amplitude of 10. So they will go plus 5 minus 5 based on what amplitude you set. Okay, and this amplitude vibrations will generate tidal volume. So in conventional ventilation, tidal volume is generated by the pressure difference between PIP and PWP. Okay. In conventional ventilation, the difference between the peak pressure and the end expiratory pressure decides your tidal volume delivery. Whereas in the stroke volume, which this area under the curve, which you see, this will decide your tidal volume. Okay, so to put it simply, HFO is nothing but a super CPAP with wiggles or super CPAP with oscillations. So that is how we can say it to be simple. So now we all know that there are two basic goals of mechanical ventilation, be it conventional ventilation, be it high frequency ventilation, and be it in adult or in a newborn. There are two basic goals of ventilation. One is oxygenation, and second is gas exchange or CO2 elimination. So when I talk about oxygenation, there are two factors which will decide how is the oxygenation. One is how much you recruit the lungs using adequate pressures. Okay, and second is the fraction of inspired oxygen. So there are two main determinants of oxygenation. One is the mean airway pressure during ventilation, and second is your fraction of inspired oxygen. Now all of us know that using high oxygen concentrations can sometimes be deleterious. So we should always try to use FiO2 minimum, and we should try to recruit the lungs as much as possible, especially when ventilating the newborns. So we have to use adequate pressures. Without using adequate pressures, if you just keep on increasing the oxygen, that may not help many times. Okay. Similarly, about carbon dioxide elimination, there are two main determinants. One is the tidal volume that is being delivered, and second is the respiratory rate. Okay, so these two decide how much will be the gas exchange or how much will be the CO2 elimination, and mean airway pressure and FiO2 decide your oxygenation. So if I want to improve oxygenation in a child, I have to increase the mean airway pressure. Either I can increase the FiO2 or I can increase the mean airway pressure. If I want to increase the mean airway pressure, the area under this graph, which you see, has to increase. Okay, so to increase the mean airway pressure, there are four options which you can do. One is you can increase the flow. So if I increase the flow, the curve which was slant initially, now it will become flat. Okay, so that is how you can increase the area under the curve and you can increase oxygenation. Second is you can increase the peak inspiratory pressure. So if you increase the peak inspiratory pressure, again the area under the curve will increase and you will increase the mean airway pressure being delivered. Third is you can increase the inspiratory to expiratory ratio. That is, you increase the inspiratory time. And when you increase the inspiratory time, again, as you can see in the third shaded portion, the area under the curve will increase. Or the last option is you increase the PWP. That is, when you increase the PWP, again, the area under the curve will increase. Okay, so this is how, these are some of the ways by which you can increase the mean airway pressure on a conventional ventilator. Okay, so when I'm talking about conventional ventilation, if I have to talk about oxygenation, if I am having a child where I want to improve the oxygenation, so one of the options is I can go upon FiO2, but then there are other options to increase the mean airway pressure. Maybe I can go high on PIP, I can go high on PWP, I can go high on FiO2 or inspiratory time, or maybe the flow. So these are the options, or these are the 5 parameters which I can meddle if I want to increase the oxygenation in the child. But then there is a flip side, that if I increase the PIP, I may have effect on CO2 elimination also. So if you increase the PIP to increase the mean airway pressure, what happens is the tidal volume delivered will also increase. And as a result, you may have more CO2 elimination and the child may go in for hypocapnia. Again, if you increase the PWP to improve the oxygenation, what will happen is it can lead to increased PWP. Once the PWP increases, what will happen is that your CO2 elimination will decrease and can lead to hypercapnia. Okay, and the third option is you can go for increase or decrease of the respiratory rate. But nowadays we are not using this. Nowadays we are more using patient-triggered ventilation. So there is not much of an option to juggle with the respiratory rate. Most of the times, if you are dealing with a problem of CO2 elimination, you have to deal or you have to tackle either of the two parameters. So what happens in conventional ventilation, that oxygenation and CO2 elimination are interdependent. Many times if you change one parameter, you may also be affecting the other, and that may adversely affect the oxygenation or CO2 elimination. Okay, so always you have to find a balance between the two, and you need to have a good understanding of the physiology to find out which parameter to adjust. But when it comes to high frequency ventilation, the oxygenation and CO2 elimination, as sir has already said, they are decoupled. So when I'm talking about oxygenation and high frequency ventilation, there are only two buttons I will be worried about. One is the mean airway pressure and second is the FiO2. And similarly, when I'm talking about CO2 elimination, there are three buttons which I will be worried about. That is your inspiratory to expiratory ratio, the pressure amplitude and the frequency. Okay, so it may not be 100% correct, but since I don't want to complicate it much, most of the times in high frequency ventilation, if you are dealing with a disease where you are struggling with oxygenation, you have to increase your mean airway pressure or FiO2. If you are dealing with a disease where you are struggling with CO2 elimination or gas exchange, then in those cases, you have to deal with either of the three buttons, that is inspiratory to expiratory ratio, amplitude or frequency. So that is where your high frequency ventilation stands over conventional ventilation. Okay. So when I talk about oxygenation, I'll not talk much about the FiO2 because again, it will make the talk more complicated. So I'll be discussing about mean airway pressure. Okay. So mean airway pressure, as I told, just like in a CPAP, it is a continuous descending pressure which is applied at the airway opening, and it is used to optimize the end expiratory lung volume. What it does is that it decreases the if you use optimal mean airway pressure, it will decrease the ventilator induced lung injury, and also it will help in gas exchange. So how to decide the starting mean airway pressure? Many times the residents, they ask this question, that with what mean airway pressure to start. So again, when you are starting a child on high frequency ventilation, there are two options. Either you can use it as a primary mode. Okay, that means a child has delivered just now, it comes to your NICU, and straight away, instead of conventional ventilation, you start on high frequency ventilation. So that is one of the options, that you start it as a primary mode. Or what majority of the times we do, we use it as a rescue mode. Okay, that means once your conventional ventilation has failed, then we move on to the high frequency ventilation. So when you're using it as a primary mode, you start at a mean airway pressure of 7 to 8 centimeters of water, and then you titrate the mean airway pressure so as to recruit the lung. Okay, so when you're using it as a primary mode, you start at a mean airway pressure of 7 to 8, and then you, based on the oxygenation and lung recruitment, you titrate it further. But if you are using it as a rescue mode, then again, there are two possibilities. Either you are dealing with a recruitable lung disease or you are dealing with a non-recruitable lung disease. So recruitable lung disease would be your preterm RDS. Okay, so the alveoli, they are collapsed. okay, and your alveoli, they are not recruited. So those are the conditions where you need to first recruit the alveoli and then start ventilating. So in those cases, the strategy will be different. And then there are certain non-recruitable lung diseases where the examples would be if the child has air leak, or if the child has meconium aspiration, or if the child has BPD. So all those would be non-recruitable lung diseases. Okay, so if I'm dealing with a recruitable lung disease, the option is that you start at a mean airway pressure 1 to 2 centimeters higher than that on conventional ventilation. So suppose if I have a baby who is on conventional ventilation and the pressure requirement in that baby is say 22/7, and the mean airway pressure on conventional ventilation is say around 11. So when that baby I shift to high frequency ventilation and I know that the child has a recruitable lung disease, then in those conditions I will start directly with a mean airway pressure which is higher than that on conventional ventilation. So if my conventional ventilation had a mean airway pressure of 11, I will start directly with a pressure of 13 on high frequency ventilator. Okay, but and then subsequently I will titrate the mean airway pressure so as to recruit the lung, as we had done in the first scenario. But if I have a non-recruitable lung diseases, especially our meconium aspiration syndromes, or maybe babies with air leaks, or babies with BPD, in those conditions, or sometimes diaphragmatic hernia. So in those conditions, you start with a mean airway pressure 1 to 2 centimeter below the that on conventional mechanical ventilation, or maybe you can start at the same mean airway pressure. Okay, so if I have a child with meconium aspiration and he's requiring a PIP of 25 and a PWP of 7 or 8 on conventional ventilation. So when I start on high frequency and say on conventional ventilation, the mean airway pressure was somewhere around 14. So when I shift that child on high frequency ventilation, I will start with a mean airway pressure of 14, or maybe I can start with 1 or 2 less. Okay, so somewhere around 12 I can start. So this is how you decide the starting mean airway pressure. Then comes, once you start the child on a particular mean airway pressure, then you need to recruit the lungs. Okay, why do we need to recruit the lungs? Because if you can see in this figure, if an alveoli is collapsed, okay, what happens? So this is an alveoli and this is the pulmonary vessel. So when an alveoli is collapsed, what happens is that there will be VQ mismatch, and whatever blood which is going through that pulmonary capillary will not be oxygenated, because you have not opened up the alveoli. There is no oxygenation. The blood is not getting oxygenated. Okay. So after giving increased pressures, if you recruit the lung, what happens is after giving increased pressures, once the alveoli are open, whatever blood is flowing through that region will get oxygenated, and there will be gas exchange through the alveoli. Okay. So to allow for good gas exchange and to allow for optimal ventilation perfusion matching, you need to recruit the lungs. Okay, and before we go to the concept of recruitment, there is a law or a principle in physics which we call the Laplace law. I know as doctors, all of us are very poor in physics, but then there are certain scenarios where you still need to, be aware of physics. So, as per this Laplace law, what he told is that if you have a cylinder, so under suppose this alveolus is a cylinder. Okay, so if you have a cylinder, the pressure which is required to open the cylinder would be equal to 2 into the surface tension divided by radius. Okay, so I'll not talk about not talk much about the surface tension, but let us talk about the radius and the pressure. So the pressure which is required to open this alveolus will be inversely proportional to the radius of the circle. Okay, so these are the two alveoli. Now say this is a de-recruited alveoli and this is a recruited alveoli. Recruited means it is already open and this is a closed. So since the radius is less, the pressure required to open it will be high. Okay, and similarly, if this is an open alveoli, the pressure required to ventilate it will be a little bit lower because your radius is high. So radius is inversely proportional to the pressure required. So the pressure required for second alveolus would be relatively less as compared to that for the first alveolus. Okay. So as I said, the pressure required for the second one will be lesser as compared to the first one. Okay, then coming to an important concept of PV loop and recruitment. So this is how your lung looks like when it is collapsed. Okay, so this is actually nothing but a pressure volume loop. Okay, and when you see it in the initial stages, so the initial black line, this entire black line is the inspiration limb, and the dotted line at the top is the deflation or expiration limb. So during the inflation limb, what happens is that initially, if you can see, there is a flat line at the bottom. So when I increase the pressures initially, when the alveoli are collapsed, so suppose this is a single alveolus. When the alveolus is collapsed, and I apply pressures, what happens is that with the increase in pressure, there is not much change in the volume initially. Okay, so in the initial time, there is not much change in the volume with the increase in pressure. After that, there comes a point beyond which if you increase the pressure, the volume starts increasing. Okay, so this uh, this is called the critical opening pressure. The point beyond which if you increase the pressure, the volume will rise exponentially. That is your critical opening pressure. Again, if you keep on increasing the pressures, there comes a point beyond which increasing the pressure does not cause an increase in the volume. Then when you start coming down, as you decrease the pressures, initially there is not much fall in the volume until a point comes when suddenly after decreasing pressure beyond this, the volume falls suddenly. So this becomes the critical closing pressure. Okay, so it is always whenever we are ventilating a patient for this, be it a newborn or an adult, it is always better to ventilate while being on the deflation limb of the PV loop, as when you are on the deflation limb. Okay, so when you are on the deflation limb, the same pressure can deliver a higher volume. So suppose if this is a pressure of say 10. Okay, so if I'm on the inflation limb, the pressure of 10 does not give me any volume. But if I'm on the deflation limb, the pressure of 10 gives me a higher volume. Okay, so always when you are ventilating a child with a recruitable lung disease, you should always recruit and open the lungs, and then you should come down on pressures. So this is just like the PV loop which I showed. So initially जैसे आप प्रेशर दोगे तो initial stages में बहुत ज्यादा वॉल्यूम लंग का नहीं बढ़ेगा until a point comes जहां पे थोड़ा सा भी प्रेशर, see here at a pressure of 12 your lungs are collapsed. जैसे ही हमने प्रेशर 16 किया तो लंग की वॉल्यूम बहुत अच्छी बढ़ गई. So this becomes the critical opening pressure. Okay, so it is a point at which a little bit increase in the pressure causes a significant rise in the volume. तो यहाँ पे लंग बढ़ गया, फिर 16 से हमने 20 किया तो वापस लंग जो है पीक पे आ गया. Again, when you are on the deflation limb, so this is the deflation limb. एक बार आपने लंग को रिक्रूट करके फिर जैसे है आप deflation limb पे जाओगे, so as you come down, the same pressure will give you a better lung as compared to that on the inflation limb. The inflation limb पे a pressure of 12 gave me a very low volume lung, but after recruitment when I come down on pressures, the pressure of 12 will give me a good lung volume. Okay, similarly a pressure of 5 4 also gives me a good lung volume until a pressure of 0 where the lung totally collapses. So then 4 becomes my closing pressure and 16 initially was the opening pressure. I think I hope you would have understood. So how to recruit the lungs? So initially, when you start the child on high frequency ventilation, you target a saturation, you target the FiO2 such that the saturation is between 86 to 94%, and you start with the mean airway pressure, maybe 1 or 2 higher than that on conventional ventilation. Then subsequently, you keep on increasing the mean airway pressure by 1 to 2 centimeters of water every 2 to 3 minutes until a point comes where suddenly after increasing the pressures, your SpO2 starts increasing. Okay. So the point at which your SpO2 improves after increasing your mean airway pressure a little bit becomes your opening pressure. Then you keep on increasing it further till a point comes where increase in the mean airway pressure does not cause any improvement in the oxygenation, or you are able to come down on oxygenation to less than 25%. So then that becomes the Pmax or the maximum pressure. And then again you come down on your mean airway pressure by 1 to 2 every 2 to 3 minutes until your SpO2 starts to fall. This becomes your closing pressure. And then once you have reached your closing pressure, you increase the mean airway pressure again over the closing pressure such that the mean airway pressure which you have set for the child should be between the Pmax and the opening pressure. Okay, so this is how you recruit the lungs. So just if you have a look at the diagram, what I will do is initially when I start on high frequency ventilation, I will keep on increasing the mean airway pressure until a point comes when after increasing the pressure, suddenly the SpO2 increases, and then I will keep on increasing till a point at which beyond further increase in the mean airway pressure, there is no increase in the oxygenation. Then I will start coming down on this thing mean airway pressure till a point where suddenly after decreasing the mean airway pressure, my lungs will collapse and my saturation will come down. And now when I know that, okay, this is my closing pressure, I will again increase it back to the recruiting pressure and then keep it a little bit lower. Okay, so this is how we do it. That initially when you start at a lower or a fixed mean airway pressure, then you keep on increasing the mean airway pressure until a point comes where you have recruited the lungs. Once you recruit the lungs, again you start de-recruiting them to see the closing pressure. And now once you know that, okay, this is the closing pressure and this is the opening pressure, I will again take my lung back to the opening pressure. Okay, so the strategy is you recruit, de-recruit, and then re-recruit. Okay, so this is how you recruit the lungs on high frequency ventilation. It may sound a little bit complicated, but I mean, if you do it in clinical practice, it will be easy. Okay. And then, so once you have started a child on a particular mean airway pressure, and once you have recruited the lungs, then how do you adjust the mean airway pressure in non-recruitable lung diseases? So if I'm dealing with meconium aspiration or maybe BPD or other non-recruitable lung conditions, how do I adjust the mean airway pressure in non-recruitable conditions? So you cannot go for that stepwise increment for mean airway pressure as you did in recruitable lung disease like RDS. In these cases, you just take the help of an X-ray to decide the lung inflation. If your diaphragm, if the lung inflation is, if the diaphragm is less than the ninth reps, then you increase the mean airway pressure. If your diaphragm is at the ninth rep, then you continue with the same pressure. And if your diaphragm is more than 9 reps, then maybe you need to come down on the mean airway pressure. So this is just a rough guide, but in non-recruitable lung diseases, it is sometimes difficult to adjust the or get the optimal mean airway pressure without causing much damage. Then coming to the second aspect, that is gas exchange or the CO2 removal during high frequency ventilation. So as I told, there are three variables. One is the pressure amplitude, one is the inspiratory to expiratory ratio, and third is the frequency. So I will talk first about the amplitude. Why? Because it is the main parameter to control the oscillatory volume. It is a key determinant of CO2 removal. So when you are using high frequency ventilation, the key determinant of CO2 removal will always be the pressure amplitude. And how much pressure amplitude to start with? So roughly they say that you can start at an amplitude of 1.5 to 2 times the mean airway pressure. So suppose I kept a child on high frequency ventilator and started a mean airway pressure of say 10. I can start with an amplitude of 1.5 to 2 times, maybe that is 15 to 20. I can start, and then it has to be titrated such that you see the vibrations of the wiggles up to the chest or the upper abdomen. Okay, so this is how you decide the optimal P amplitude. Okay, so to start with, you start it at 1.5 times to 2 times the mean airway pressure, and then you see how or till where you are getting the chest vibrations. Sometimes it may happen that your wiggles or vibrations, they may go even up to the lower limb. Then in those cases, you need to come down a little bit. Okay. Then there is an important concept of pressure dampening. So many times, residents, they asked me in rounds also that we are using such high pressures, how can it be safe, or how can it be less injurious? So there is a concept called pressure dampening. Okay, so what happens is, since you are using very small tidal volumes at a very high rate, the pressure amplitude which you are giving at the opening of the airway will be very high. But as you go down, because of the respiratory mechanics, because of the resistance of the endotracheal tube, because of the compliance and resistance of the respiratory system and the inertance of the lung system as such, this amplitude keeps on decreasing. So the amplitude which you deliver at the beginning will be very high, but when you trace that same amplitude at the carina, it will be less. And when it comes to the alveoli, it will even be lower. Okay. So what reaches on to the alveoli effectively is actually a very less amplitude. And that is why it may sometimes not be very detrimental. Okay. So as you can see in the picture here, that at the airway opening. So what happens in conventional ventilation? So this black line which you see is conventional ventilation. So conventional ventilation, what happens is, whatever pressure I set at the airway opening, that same pressure goes to the larger airways, and that same pressure is delivered to the alveoli. But when I talk about high frequency ventilation, the vibrations which you see at the back, the blue lines. So the blue lines, they are very high at the airway opening, but at the larger airways, they will be little bit less. And as you come down towards your alveoli, the vibrations will be minimal. Okay, so that is how your lungs get protected and they do not cause much of a damage. Again, one important point in this picture is that if you can see, there are two graphs. One is for the compliant lungs and one is for the non-compliant lungs. So the compliant lung means a normal, healthy term lung. So in a term lung, what will happen is the pressure dampening will be more. Okay, so if you have set a pressure of 25, what reaches onto the this thing to the alveoli, the this thing amplitude will be very less. But if it is a non-compliant lung means your RDS lungs. In those babies, what happens is whatever pressures you set, there will be pressure dampening, but it will be relatively lesser. So here the pressure which is reaching onto the alveoli is relatively less, but here you are able to transmit a relatively higher pressure onto the alveoli. The implications of this we'll discuss in the next slides. Then what is the effect of respiratory mechanics? So whenever the compliance is low, you need to use a higher pressure amplitude. And whenever the disease is like BPD or MAS, where the resistance is high, again, the pressure amplitude requirement may be high. Then coming to the next parameter, that is frequency. So frequency, what happens is during conventional mechanical ventilation, what happens is if you increase the respiratory rate, that is what we do, right? If we are dealing with a child where CO2 retention is a problem, what we do, we'll increase the respiratory rate. So as the frequency increases, minute ventilation increases, and there is more CO2 removal. That is what happens in conventional ventilation. But that is not the case with high frequency ventilation, because if you increase the ventilation frequency, the absolute oscillatory time for each cycle decreases. And as the time available for gas exchange decreases, with an increase in the frequency, less tidal volume is delivered. And that is why with an increase in frequency, you are actually causing more CO2 retention. Okay, so gas elimination will decrease if you increase the frequency too much. Just if you have a look at this figure, if you are using a frequency of 5 hertz, the tidal volume delivered will be somewhere around 3. Now, if I'm using a frequency of 10 hertz, the tidal volume which I'm delivering is just 2. And if I increase it to 15, my tidal volume delivered will be 1. Okay, so ultimately, we all know that gas exchange depends on the tidal volume which is delivered. And so if I increase the frequency, the tidal volume delivered will decrease. And that is why you have less time available for gas exchange and your CO2 will increase in high frequency ventilation. So it is actually reverse than what happens in conventional ventilation. Then how to decide the frequency? Okay, you cannot start with the same frequency for all the babies. There are many factors to take into consideration while selecting the frequency. One is what is the lung pathology and mechanics, what is the size of the baby, and what is the risk of lung injury. So if I have a baby where the size is just to give you a rough idea that the bigger the baby, the lower the frequency we use. So if I'm having a term baby, I will use a little bit lesser frequency. If I am having a preterm baby with RDS, the frequency used will be a little bit higher. Similarly, if there is a higher risk of lung injury, I will use a little bit higher frequency. If there is a lower risk of lung injury, I will use a lower frequency. Okay, so if I'm talking about RDS with homogeneous lung disease and stiff lungs and low volumes, I will use a higher frequency. And if I'm talking about obstructive lung conditions like BPD or MAS, then in those cases, the resistance is high, so I will use a relatively lesser frequency. And if I want more CO2 removal, definitely I have to have a lower frequency. Okay, so this is just a figure to show how much frequency we can start for our various neonatal diseases. So I'm talking, if I talk about preterm RDS, the frequency has to be 12 to 15. If I talk about meconium aspiration, term babies, the frequency has to be 6 to 10. Now, what is PIE? Can someone tell me what is PIE? So it is actually pulmonary interstitial emphysema, a sort of air leak which is seen more commonly in extreme preterm babies with very immature lungs. So here in those conditions only we will use a higher frequency. Why? Because the lung is already damaged. We don't want to damage it further. So that is why we use a lower frequency. So again, this figure also shows the same thing that for a preterm, for a child who is in early stages of volutrauma, I'll use a higher frequency so that the volutrauma can be decreased. If it is a preterm with RDS, I want to minimize the volume exposure and also the lung size is small. So I will use a relatively higher frequency. If I have a baby with diaphragmatic hernia, so already the lung is at a higher risk. Diaphragmatic hernia mein kya hoga ki there is already one lung which is hypoplastic and the other lung is also sometimes not healthy. So I don't want a ventilation strategy which is causing more volutrauma. That is why I will use a higher frequency so as to decrease the volutrauma. Okay, and meconium aspiration and other gas trapping syndromes, we have to use a relatively lower frequency, somewhere around 7 to 10. And the last one, which you can see, cystic conditions with high FiO2. So these are the conditions जहाँ पे lung injury volume associated हो चुका है, and your elasticity is less, gas trapping is less, and the time constant is longer. So this is typically what you see in BPD. So in babies with BPD, we will set a lower frequency. Then comes to inspiratory to expiratory ratio. So as sir said, there is always a debate when using high frequency ventilation, whether to use a frequency inspiratory to expiratory ratio of 1:1 or 1:2. Simply, I can say that maybe if you're dealing with a condition where you are struggling with oxygenation, you increase the inspiratory to expiratory ratio as 1:1, because 50% of the time will be in inspiration, so you will get more time for oxygenation. And if you are dealing with a condition jahan pe gas exchange or CO2 elimination is the problem, then you increase the I/E ratio to 1:2. Again, it may not be true for all the diseases, but this is just a rough guide. Okay, so this figure also, if you see carefully, when I keep a frequency of, when I keep an I/E ratio of 1:1, the tidal volume which is delivered is somewhat higher as compared to the I/E ratio of 1:2, where the tidal volume will be less, because there is lesser time available for inspiratory cycle, so tidal volume delivered will be less. Okay, then comes to the coefficient of gas transport, or DCO2. So it is not a controlled parameter, and it is a sometimes we cannot control it. It is a critical determinant of gas mixing and success of high frequency ventilation. So during conventional ventilation, we all know that CO2 removal is actually nothing but tidal volume into respiratory rate. But when it comes to high frequency ventilation, the CO2 removal is actually nothing but a square of tidal volume. I'm sorry, this 2 has come small, but in the subscript, but it has to be superscript. So it is actually nothing but a tidal volume square into the frequency. Okay, so जैसे ही आपका tidal volume delivered बढ़ेगा, your CO2 elimination will rise exponentially in high frequency ventilation. So DCO2 is actually an absolute value, and I mean you cannot have a single value के कितना हमको उसको target करना है, but so as the tidal volume increases with the increasing size of the patient, the DCO2 also rises exponentially. There is not a single value, but as sir has also mentioned, that DCO2 per square of baby's weight in kgs will be useful. It is a more reliable variable. Okay, so DCO2 upon the weight of the baby in square kg square, that will give you value which you have to target. So in normal ventilation, we usually try to target a DCO2 per kg square value of 40 to 60 ml per kg square per second. Okay, so if you see your ventilator, in our ventilators also we have the option of DCO2. Many a times we don't see it, we don't titrate it, but so as you improve, as your gas exchange improves, as your CO2 elimination improves, the DCO2 values will come down, but there is no fixed way by we can titrate it. So what we do is we use it for every baby as per the kg. Okay, so DCO2 per kg square will give you a better guide. Okay, so if this child is on high frequency ventilation, and if I want to increase the CO2 removal, so there are two options available. Either I increase the amplitude or I decrease the frequency. So yeah, so if I decrease the frequency, so if you can see here, this was what initially. Now as I decrease the frequency, the stroke volume, the area under the curve improves, and so there is more time available for gas exchange, so there will be better CO2 removal. Also, if I increase the amplitude, again the area under the curve improves, and so there is more CO2 washout. Similarly, if you want to decrease the CO2 removal, there are two strategies. One is that you increase the frequency or you decrease the amplitude. So when I increase the frequency, again the area under the curve decreases, there is less time available for gas exchange. Or if I increase the frequency, again it will be the same. Okay, then coming to the last part, that is the disease specific ventilation strategies. So that is always what we say, that one size does not fit all. So it has to be tailor made, it has to be titrated as per the baby's lungs. So for a preterm RDS, just a rough guide, preterm RDS, what happens that your compliance is low, resistance is normal, the time constant is low, FRC is low, and the lung size is also low. So definitely in these babies, we adopt a high volume strategy. That is, you go for recruitment initially, and you start with a mean airway pressure 2 centimeters higher than that on conventional ventilation. You carry out the recruitment process, and you start with an amplitude 1.5 to 2 times, and you target it as per the wiggles of the chest and monitor the DCO2 levels. Because it is a preterm lung, small lung, as I told you, we have to start with a higher frequency. So around 10 to 15 hertz would be the starting frequency. And since we are dealing with oxygenation, the I is to E ratio will be around 1 is to 1. Okay, because we want to improve the oxygenation. When it comes to air leaks, what happens is your compliance is normal. The resistance would be high because of the air leak which is sitting. The time constant may be high or it may be normal. FRC would be normal, and the lung size may be normal or it may be decreased. So in air leaks, you definitely adopt a low volume strategy. You start at a mean airway pressure, same as that on conventional ventilation, or maybe a little bit lower also would be fine. And you target a low mean airway pressure at the cost of a higher FiO2. Okay, these are the conditions जहाँ पे आपको FiO2 को कम नहीं करना at the cost of pressures. You have to accept a higher FiO2. You have to accept a higher PaCO2 also. And definitely there is no need for a recruitment process, because already you have an injured lung, and you start with an amplitude around 1.5 times the mean airway pressure, and then monitor subsequently. Frequency, again, here also you have to have a higher frequency because you have a damaged lung. You don't want more pressure to get transmitted. So that is why you use a higher frequency, so that there is lesser time available for the pressure to get transmitted. And the inspiratory to expiratory ratio would be 1 is to 2, because you want more gas to go out and you don't want air trapping to happen. So you allow a I is to E ratio of 1 is to 2. Coming to meconium aspiration, again, the problem would be that resistance is high, time constant is high, FRC may be normal or it may be high, and the lung size is normal most of the times. So in this case also, if you are dealing with a bad lung or a patchy lung, or lung which is otherwise expanded in some areas and unexpanded in certain areas, it is better to go for a low volume strategy. You start with a mean airway pressure, same as that on conventional ventilation. You target a mean airway pressure at a lower mean airway pressure at a higher FiO2, and definitely no need for a recruitment process. You titrate your amplitude and frequency here, because it is a bigger lung, and you want more time for gas exchange and CO2 removal. You will start with a lower frequency of 5 to 9, and inspiratory to expiratory ratio is 1 is to 1 if you are struggling with oxygenation, and if CO2 elimination is the problem, you can go up to 1 is to 2. Then coming to diaphragmatic hernia. So as I said, these are actually bad lungs. They are hypoplastic lungs, decreased gas exchange units. So more chances of lung injury if you use a higher mean airway pressure. Best strategy is that you use a higher frequency that allows a lesser tidal volume delivered, low mean airway pressure at the cost of higher FiO2. And inspiratory to expiratory, again, you keep a ratio of 1 is to 1. So if there are any further questions, you may ask. Otherwise, I think we'll move on to the next talk because ma'am would be getting late.